So you've had your blood test back and you've been told your cholesterol is high. Maybe it sounded like a mild warning, or maybe it felt more like a ticking clock. Either way, it tends to land the same way in your head. Confusion, worry, and a flood of questions. Is this because of my diet? Do I need medication? Am I about to have a heart attack? And perhaps the most confusing of all, why do I feel completely fine? If you've asked yourself those questions, then this video is for you, because cholesterol becomes a lot less scary when you understand two things: what the numbers actually mean and why they can be high even when you feel like you're doing everything right. If it's your first time here on my channel, welcome. My name is Hafiz and I'm a cardiologist based in London. I create videos to help to keep your heart healthy and explain heart conditions in a way that I hope is easy to understand. If that interests you, then click on the subscribe button and bell icon so you get notified every time I release a video. Let's start with the single most important idea. Cholesterol is not one number. A cholesterol profile is a set of related measurements that describe how fats are being carried around in your blood. If someone tells you your cholesterol is high, but only gives your total cholesterol, that's like telling you your finances are bad, without showing you income, spending, savings, and debt. The detail matters because two people can have the same total cholesterol and completely different risk patterns depending on what makes up that total. Most standard lipid profiles include total cholesterol, HDL cholesterol, non-HDL cholesterol, triglycerides, and often LDL cholesterol plus a ratio such as total cholesterol divided by HDL. In the UK and Europe, these are usually reported in millimoles per litre. In America, it is usually milligrams per deciliter. The units look different, but the biology is the same. Now, what is cholesterol in the first place? Cholesterol is a fat-like substance your body uses to build cell membranes, make hormones, and produce bile acids to help digest fats. Your liver makes most of the cholesterol you need. So cholesterol is not poison, it's a normal building material. In fact, it is essential for life. The reason we care about cholesterol levels is that certain cholesterol-carrying particles, when present in high amounts over many years, increase the buildup of fatty material inside your artery walls. That buildup process can narrow arteries and, more importantly, create plaques that can rupture and cause clots. That's the pathway that leads to heart attacks and strokes. And the frustrating part is that you typically don't feel any symptoms while this is happening, which is exactly why the numbers matter. Here's the key detail. Cholesterol doesn't float around in your blood on its own. It's carried in tiny particles called lipoproteins, like little transport trucks. Different trucks carry cholesterol in different directions, and they're associated with different levels of risk. So when you look at your cholesterol numbers, you're really trying to answer how much cholesterol is being carried in the types of particles most likely to contribute to plaque buildup. Let's talk about each number one by one, in plain language, and then I'll show you how to interpret them together as a pattern. Total cholesterol, often abbreviated TC, is the total amount of cholesterol in your blood across all particle types. It includes cholesterol carried in LDL particles, HDL particles, and other cholesterol-carrying particles. Total cholesterol is a useful headline, but on its own, it can mislead you because it doesn't tell you what's making up the total. A high total could be high because your protective HDL is high, or because your plaque-forming particles are high, and those are very different situations. So total cholesterol is step one, not the conclusion. HDL cholesterol is commonly called good cholesterol. A simple way to think about HDL is that it's involved in reverse transport, moving cholesterol away from tissues and back towards the liver for processing and removal. Higher HDL is generally associated with lower cardiovascular risk, and HDL is often a marker of healthier metabolic pattern, more activity, less smoking, better insulin sensitivity. But there's a nuance that matters. A high HDL does not magically cancel out a very high LDL or non-HDL. Think of HDL as one protective factor in the mix, not a force field. Non-HDL cholesterol is one of the most useful numbers on the entire report, and many people have never been told what it is. Non-HDL is simply your total cholesterol minus your HDL. That's it. If your total cholesterol is 6 and your HDL is 1.5, your non-HDL is 4.5. So what does that mean? It represents the cholesterol carried in all the particles that are more likely to contribute to plaque buildup, not just LDL, but also other atherogenic particles that can be linked with higher triglycerides. This is why non-HDL is often a practical treatment focus. It captures the total burden of the cholesterol that can drive artery disease, especially when triglycerides are elevated. LDL cholesterol is the one everyone has heard of, the classic bad cholesterol. LDL particles deliver cholesterol from the liver to the rest of the body. That's a normal job. But when LDL cholesterol stays high, LDL particles are more likely to enter artery walls and contribute to plaque buildup over time. So LDL matters because it is directly tied to the biology of atherosclerosis. Lower LDL is generally better, especially if you are at high overall cardiovascular risk. Here's an important technical detail that helps explain why your report might look odd. LDL cholesterol is sometimes measured directly, but very often it is calculated from your other values. A common calculation uses your total cholesterol, HDL cholesterol, and triglycerides to estimate LDL. In millimoles per litre terms, it's essentially total minus HDL minus a triglyceride-related adjustment. That calculation becomes unreliable when triglycerides are high, and a widely used rule is that the traditional calculation is not valid once triglycerides get above roughly 4.5 millimoles per litre. When triglycerides are that high, your doctor or the lab may repeat a fasting test, use a different equation, or measure LDL directly. So if your report says LDL calculated and your triglycerides are high, don't overinterpret the LDL number. Focus on non-HDL and the overall pattern, and let your doctor decide the best way to measure and track LDL. Triglycerides are the other major number on the lipid panel, and they are not cholesterol. Triglycerides are a type of blood fat used for energy storage. Your triglycerides are influenced strongly by what you've eaten recently, your alcohol intake, your body's insulin sensitivity, and whether you carry weight around the middle. Triglycerides can be a powerful clue about your metabolic health. Mildly raised triglycerides are common, but very high triglycerides are a different situation because extremely high levels increase the risk of pancreatitis, which is a serious illness. So triglycerides matter both as a cardiovascular risk clue and at extreme levels as an urgent safety issue. Finally, you may see a ratio, often total cholesterol divided by HDL, or sometimes non-HDL divided by HDL. Ratios are used in risk calculators because they capture balance. How much total cholesterol do I have relative to my protective HDL? Lower ratios are generally better, but if your HDL is very high, your ratio can look reassuring even when your non-HDL and LDL are still high enough to matter. So ratios are useful as part of overall risk assessment, but you should not use a nice ratio to ignore a clearly elevated non-HDL or LDL. Now let's talk about the guide ranges people often hear, because this is where confusion and anxiety start. For healthy adults with no known cardiovascular disease, common guide ranges in the UK are total cholesterol below about 5 millimoles per litre, non-HDL below about 4 millimoles per litre, HDL above about 1 millimoles per litre for men and above 1.2 millimoles per litre for women, and LDL below about 3 millimoles per litre. For triglycerides, a common guide is fasting triglycerides below about 1.7 millimoles per litre and non-fasting triglycerides below about 2 millimoles per litre. These are general guides for healthy adults. The moment your risk is higher, for example, you have established cardiovascular disease, diabetes, chronic kidney disease, or a strong family history, doctors usually aim lower because the benefit of lowering LDL and non-HDL is greater when baseline risk is higher. So your personal target is not always the same as the general healthy range. That's why two people with the same LDL can get different recommendations depending on the risk of their risk profile. Also, a quick practical point that surprises people: for total cholesterol, HDL and non-HDL, it usually doesn't make much difference whether you ate before the test. That's why many lipid profiles are now taken non-fasting. Triglycerides are the big exception. They can rise after meals. So if your triglycerides are borderline or high on a non-fasting sample, your doctor may repeat them fasting to get a clearer baseline, and they may interpret LDL differently if LDL was calculated. Okay, now you know what each number means in isolation. The next step is learning how to read the profile as a pattern, because risk and treatment decisions are rarely based on one number alone. I'm going to give you a simple method you can use every time you look at a lipid panel. Step 1, look at non-HDL, because non-HDL captures the cholesterol carried in all the particles that can contribute to plaque buildup. It's often the most useful big picture number. If non-HDL is in a healthy range and HDL is decent, your risk from blood fats is likely lower, even if total cholesterol looks a bit high. If non-HDL is high, that is usually the number you're trying to bring down over time. Step 2, look at triglycerides and HDL together. This pair is a strong clue about metabolic health. High triglycerides plus low HDL is a classic pattern linked with insulin resistance, central weight gain, excess alcohol, and diets high in refined carbohydrates and sugar. Normal triglycerides with normal HDL suggests a different driver, often more about saturated fat intake and genetics. Step 3, look at LDL, but check whether it's calculated and what your triglycerides are doing. If triglycerides are high, LDL calculation may be unreliable, and you may need a repeat fasting test or a direct measurement. If triglycerides are not high, LDL tends to be a reliable and important number. Step 4, use the ratio as a supporting detail, not the main decision maker. A good ratio is nice, but it doesn't override high non-HDL. Now let's make this real with examples, because numbers make sense faster when you see patterns. Example 1, total cholesterol 6.2, HDL 2, non-HDL 4.2, triglycerides 1, LDL 3.2. At first glance, total cholesterol looks high, but HDL is high, triglycerides are low, and non-HDL is only slightly above the general guide. This profile often belongs to someone who is active, has favorable HDL, and a mildly elevated LDL non-HDL ratio. The main focus would likely be whether their overall risk is low or high. If risk is low, lifestyle changes might be enough. If risk is high, doctors may still treat with medication, because even small LDL reductions can matter when risk is high. The point is, this is not the same as someone with the same total cholesterol driven by high non-HDL. Example 2. Total cholesterol 5.8, HDL 0.9, non-HDL 4.9, triglycerides 2.4, LDL may be calculated around 3. Here, total cholesterol doesn't look dramatically high, but the pattern is much less favorable. HDL is low, triglycerides are high, and non-HDL is clearly high. This is a classic metabolic pattern, and it often improves with weight loss, improved diet quality, reduced alcohol, increased activity, better sleep, and addressing insulin resistance. In this profile, focusing on total cholesterol would miss the real issue. Example 3, total cholesterol 7.8, HDL 1.3, non-HDL 6.5, triglycerides 1.1, LDL 6. This is a very high non-HDL and a very high LDL with normal triglycerides. This pattern raises the possibility of a strong genetic contribution, especially if there's a family history of early heart disease or stroke. Lifestyle still matters, but lifestyle alone may not bring LDL down enough, and medication is often considered earlier. The key is not to self-blame, it's to recognize that some people's baseline LDL is high because of how their body clears LDL from the blood. And finally, example 4, triglycerides 8, 10, 15 or higher. At that point, the priority shifts. LDL may be difficult to calculate reliably, non-HDL is still important, and the immediate goal becomes finding and fixing the drivers of severe triglyceride elevation, often uncontrolled diabetes, heavy alcohol intake, or genetic triglyceride disorders, because the pancreatitis risk becomes a serious concern. That situation needs prompt medical management rather than casual lifestyle tweaks. Now let's answer the question people rarely ask but should. Why would a doctor focus more on non-HDL than total cholesterol? Because total cholesterol includes HDL, and HDL is generally protective. A high total driven by high HDL is not the same risk as a high total driven by high LDL and other atherogenic particles. Non-HDL removes HDL from the equation and concentrates on the cholesterol carried in the particles that contribute to artery narrowing. It's basically a cleaner signal. You might also wonder why your LDL isn't always shown or isn't always treated as the only key number. Part of it is measurement. As we said, LDL is often calculated and triglycerides can distort the calculation. Another part is practicality. When triglycerides are elevated, non-HDL can be a more stable target because it remains meaningful even when LDL estimation becomes less reliable. At this point, you might be thinking, so what should I do with my numbers? Here's a list of things you can do. First, can you confirm the full breakdown? Total, HDL, non-HDL, triglycerides and LDL, and whether LDL was calculated or measured. That one question instantly improves understanding. Second, are your triglycerides fasting or non-fasting? And do they need repeating fasting? If triglycerides are high on a non-fasting test, repeating fasting can clarify whether it's a true baseline issue or a post-meal effect. Third, what is your overall cardiovascular risk over the next 10 years? And how do your cholesterol numbers contribute to that risk? In the UK, doctors often use a formal risk score for this, like Q-risk, and that score can guide how intensively to treat. Fourth, given your risk, what target are we aiming for? A specific non-HDL or LDL level or a percentage reduction from baseline, and when should you recheck? Having a target turns a scary number into a plan. Fifth, is there a reason to suspect an inherited cholesterol problem? This becomes relevant if LDL or non-HDL are very high, if high cholesterol runs in the family, or if there's early cardiovascular disease in close relatives. And finally, are there any secondary causes you should rule out, like thyroid problems, diabetes, kidney issues, or medication effects? This matters because sometimes cholesterol is high because of an underlying condition that can be treated. Now I want to address something that causes a lot of unnecessary fear. The idea that you can feel cholesterol or that symptoms tell you whether your numbers matter. Cholesterol is usually silent. You can have an unfavorable profile and feel fine. So the purpose of this information isn't to scare you, it's to help you prevent problems before they happen. Prevention always feels less dramatic than treatment, but it's far more powerful. Let's talk briefly about what tends to move each number, because it helps you look at your profile and choose the right lever rather than trying everything at once. LDL and non-HDL tend to respond most to saturated fat intake, overall diet quality, soluble fiber intake, weight change if overweight, and genetics. If LDL and non-HDL are the main problem and triglycerides are normal, think less saturated fat, more unsaturated fat, more soluble fiber, and check for genetic contribution. Triglycerides tend to respond strongly to alcohol intake, sugary drinks, refined carbohydrates, weight around the middle, insulin resistance, and physical inactivity. If triglycerides are high and HDL is low, think metabolic, reduce alcohol if relevant, reduce refined carbs and sugar, move more, improve sleep, and aim for gradual weight loss if needed. HDL often improves with physical activity, smoking cessation, weight loss if overweight, and better insulin sensitivity. But again, HDL is not the sole treatment target, it's part of the pattern. Ratios improve when non-HDL drops and when HDL improves, but a nice ratio should not distract you from a high non-HDL. Now, one more thing that helps you interpret results: trends over time. A single lipid panel is a snapshot. Trends tell a story. If your non-HDL has gradually climbed over 5 years, it may reflect aging, subtle weight gain, less activity, diet drift, or menopause. If your triglycerides suddenly jumped, it may reflect a change in alcohol, diet, weight, blood sugar control, or a medication change. If your LDL is very high and has been high consistently despite lifestyle changes, that suggests genetics may be playing a stronger role. Trend turns guesswork into pattern recognition. Also, timing and context matter. Pregnancy can significantly raise cholesterol and triglycerides, so testing during pregnancy can be misleading. Acute illness can also shift lipid values temporarily. Medication changes can shift values, so if a result looks out of character for you, it's sometimes sensible to repeat it rather than building a lifelong identity around one lab report. At this point, I'd like you to pull up your latest cholesterol profile and write down your 5 cholesterol numbers: total cholesterol, HDL, non-HDL, triglycerides, and LDL, plus whether you are fasting. If you don't have all 5, you can still work with what you have, but if you only have total cholesterol, make a note to ask for the breakdown. Category 1 is LDL or non-HDL dominant. Non-HDL is high, LDL is high, triglycerides are normal-ish, HDL may be normal. This often points towards saturated fat and genetics as major drivers. This is the category where people often benefit most from changing fat quality and increasing soluble fiber, and where medication is most commonly considered if the numbers are high or risk is elevated. Category 2 is triglyceride or HDL metabolic. Triglycerides are raised and HDL is low, with non-HDL sometimes elevated as well. This often points towards insulin resistance, weight around the middle, alcohol and refined carbs, and inactivity, because the bigger driver is carbohydrate handling and metabolic health. Category 3 is mixed or very high. Multiple numbers are high, or one number is extremely high. This is where you ask about inherited conditions, secondary causes, and you treat the results seriously rather than hoping a single diet tweak will fix it. Once you've identified your category, your plan becomes much clearer. If you're LDL or non-HDL dominant, your lifestyle focuses reduce saturated fat sources that are frequent and hidden, swap towards unsaturated fats, increase soluble fiber daily, and build consistent activity. If you're triglyceride or HDL metabolic, your focus is reduce alcohol if relevant, reduce sugary drinks and refined carbs, improve meal structure, increase activity most days, and address weight and sleep. If you're mixed or very high, your focus is confirm the numbers, check for secondary causes, consider inherited risk, and discuss medication earlier. Let's also clear up a few myths that cause people to chase the wrong thing. Myth 1, My total cholesterol is fine, so I'm fine. Not necessarily. You can have a normal total cholesterol, but an unhealthy balance. Low HDL, high triglycerides, high non-HDL, and that can still be a concerning pattern. Myth 2, my ratio is fine, so I'm fine. Ratios can look fine because HDL is high, even when non-HDL and LDL is still high. Ratios are supportive information, not the whole story. Myth 3, if I'm slim, cholesterol can't be high. It can, particularly if genetics drive higher LDL. Weight is not a perfect predictor. Myth 4, if I just stop eating cholesterol, my blood cholesterol will fall. For most people, the bigger dietary driver of LDL is saturated fat and overall dietary pattern rather than cholesterol in foods. So obsessing over single foods often misses the bigger levers. Myth 5, if I feel fine, it's not serious. Cholesterol is usually silent. It matters precisely because it doesn't announce itself. Now let's end with the simplest message I want you to remember. If you forget every number, remember this. The number you generally want low is non-HDL because it reflects the cholesterol carried in plaque-forming particles. LDL is also a key bad cholesterol number, but it may be calculated and can be less reliable when triglycerides are high. The number you generally want not too low is HDL because it's associated with protective patterns. Triglycerides tell you a lot about metabolic health and alcohol or sugar handling, and extremely high triglycerides are a special situation that needs prompt medical attention. Total cholesterol is the headline, the breakdown is the story. And your personal targets depend on your overall cardiovascular risk, not just one isolated lab result. Let me know in the comments below if you had your cholesterol measured. Thanks so much for watching. If you found this explanation helpful, please give the video a thumbs up, subscribe for more cardiology insights, and share it with someone who might benefit. See you next time.